friends, for those of you that are new here, I'm Dr. Meggs, and this is Everyday Vet, where we bridge the communication gap between medical professionals and pet owners. Today I'm going to walk you through a dog spay surgery. I do have two versions of this video available. The other version is one where it is non-narrated and you'll get an uninterrupted view of the actual surgical procedure. I do have a link in the video description below if you're more interested in that. But in this version, I'm going to be annotating, narrating, and walking you through the procedure and explaining a little bit more in depth as to what I'm doing. So let's get started. Looks like I've just laid down that surgical drape. That's to prevent any contamination from outside of the surgical field from entering in. And I have the scissors right there in my right hand, and I'll be making an incision in that drape right over where we're going to be making the incision. So the other important thing to note too is that there is some variability in regions on how the surgery is done. In the United States, it's standard procedure to do an ovariohysterectomy. So that's going to be surgical removal of the ovaries as well as the uterus. But that's not true in all countries. So just note that I am doing the ovariohysterectomy surgery in this video, and because of that, I am making a ventral midline incision. So basically that just means that we're cutting through the skin on the abdomen of the dog, whereas elsewhere in the world, sometimes they do more of a flank approach, so they make the incision on the side of the dog. So this dog is actually laying on her back, so that way I can access her abdomen. So I've made a nice long opening in my drape there, and then I'm using these towel clamps here just to kind of adhere that surgical drape down to that skin layer. When I'm doing my surgery, I don't want the drape to slide, because if the drape slides over the surgery site, the drape that's been touching the non-prepped hair and skin of the dog outside of my surgery field will then be dragged over the surgical site and can bring bacteria and debris in with it. So it's really important that we clamp that surgical drape down to the skin layer.
And there's another blade.
So now we're just getting our instruments prepped. So you can see here that the assistant is pouring in some sterile saline. The surgical laser that we use is a CO2 laser, and the CO2 laser beam cannot cut through the saline, so we'll often use that to protect the body while we're making different cuts. So now I am getting ready to make that skin incision. You can see up here there is the hose that it's attached to the vacuum, so that'll suck up the fumes from the laser. And then down here I'm just making that incision through the skin layer. The top layer is going to be the epidermis, the layer beneath it is the dermis, and that's what I'm cutting through right now. You can see there are some fumes there from the cut that I'm making, but they're getting sucked up by that vacuum tube. I'm also applying some tension here as I spread out the skin layers. That just helps me get a more accurate cut.
I've made my skin incisions, and I'm just going to extend it down to the tendon of the body wall muscles.
So just to point out what I'm talking there, so I said that I've made the skin incision, I'm going to extend it down to the tendon of the body walls. So you can see right here in the middle of my incision, there's actually this white line, and that's going to be the linea alba. So that's still covered by the subcutaneous layer, which sits just beneath the dermis. But once we get down to there, that is going to be the connective tissue of the muscle bellies that make up that body wall. And we want to get down to that linea alba because that's going to be where I'm entering the abdomen from. And I'm just going to take those Metzenbaum scissors to bluntly dissect. So there I'm using the scissors to kind of poke into the subcutaneous layer, but spread them out then. So I'm spreading the tissue to make it thinner, so that way when I make my cut, I know I'm not cutting through any important blood vessels or nerves and whatnot. So now I'm making that cut. Now I've got a little bit thinner, and we can start to see the more bluish purple tint of those muscle bellies underneath as well. fingers, just grasping that linea alba to see if I had enough visibility of it. But there is still some tissue adhered down to it, so that's why I'm continuing a little bit more dissection there.
Dissecting under the subcutaneous fat so I can get better exposure of that linea alba, which is where I'm going to enter the abdomen through. That's better.
And there I'm grasping onto that linea alba and lifting it up, but I'm also noticing that there's still some tissue connected down to that muscle layer. When I make my incision into the abdomen, I want to make sure that I'm directly over that tendon. I don't want to be cutting through the subcutaneous layer as well, because if I do that, then I might miss where the actual linea alba is, and I may unintentionally make an incision into the muscle belly instead. So that's why I'm focusing so much right now on getting good visibility. I want to make sure that I know exactly where I'm cutting, and I'd rather take the time to get it nice and clean before making the incision than make an incision not where I'm intending to do. Now, if you do miss the linea alba and make a little bit of an incision through the muscle belly, it's not the end of the world. You can definitely suture it up and include it in your closure at the end of the surgery, but it's much simpler, more comfortable for the patient if we do make sure to actually stay on that linea. So that's why I am taking a little bit more time at this step, just to make sure that we get exactly where we're trying to go.
So I'm going to hold that up. I'm going to enter into the abdomen at a 45-degree angle. This way I can get in there without entering any of the organs unintentionally. So I make my little incision there. I'm going to insert my hemostats. Put this under to protect the abdomen. And I make my cut to really enter.
I'm just cutting over the actual hemostat. By leaving that in there like that, I know that the only thing between the hemostat and the laser is that linea alba that I want to make my incision on. I know that there's no intestinal organs stuck up there, so I'm not going to accidentally cut through tissue that I don't want to. So it's just an added layer of safety. I can also line up that linea nice and centered on the hemostat, so it helps me make a good straight line.
The bladder here on the
There's the
right.
bladder there.
And if I move it over, I should find the uterus right underneath it.
So the bladder sits more on top, the uterus is underneath it, and then the colon.
About on the sides of it. So I can see the uterus branches into two sides. There's the body, the horns. If I also pull it up, I can see that there's a vessel that travels right along the uterus, so that's another good way to indicate that this is in fact uterus. And then if I follow it all the way up, I should reach the ovary. And there it is.
So I'm just going to zoom in on that right here for you guys. So I've got the body of the uterus up here. Following it down here is the proper ligament, That's going to be the ligament that attaches the uterus to the actual ovary, and the ovary is this little round thing here sitting down behind my finger.
Important distinction, because this is an intestinal loop which looks very similar, does not have the same blood supply, and I definitely don't want to remove that. We've got a window here. Clamp across this ligament. It's the proper ligament that attaches the uterus to the ovary. Pull this back. I'm going to reach in, and I'm going to loosen the ligament that's holding the ovary up to the body wall. So I'm just applying pressure with my finger so I can feel that loosening, making sure to stay on the ligament because I don't want to disrupt the blood supply. Okay, it's loosening, so I can lift this up a lot higher out of the body, but it's still pretty tight. And keep going.
There's a ligament that goes forward to attach the ovary down, and that's what I'm trying to loosen up right now. But then there's also blood vessels that go down to the body wall, which I'm not trying to loosen. It's definitely something by feel, because we can't really visualize it until it's loosened up.
I'm going to extend this little window down that I made. Now, to make things easier, get better visualization of the ovary, make sure I remove the whole thing, use a Dowling retractor. Just fold it all up out of the abdomen. Stick that to here. And I'm going to fold it back like that. So now I've got the ovary here that's ending there, and I've got the blood supply, so I need to close that off. That way she doesn't have excessive bleeding once I remove the ovary. Clamps on here. So I'm going to do, actually, I'm going to do a transfixing one. And put it in there.
Alright, so let me just show you a little bit more what I did here. So I passed that suture around behind here. So again, these are the vessels, ovaries up here, body of the uterus there. So these are the big vessels that I want to make sure that I close off with the suture. So I did a transfixing one, which means it's anchored in the middle of those actual vessels. So I passed it around and up through the middle of those. And this is where these really come in handy, this tool that I'm using there to elevate the pedicle out of the body. I don't have to use that. The other option would be to put like another clamp here and do what's called like the 3-clamp technique. But the problem with that is that I'm then trying to stick the needle kind of more into the abdomen and come up through those and make sure I don't hit anything important. Whereas with this, since I've got this arm here coming off of it that sits underneath those vessels and holds it up out of the abdomen, I can see exactly what I'm doing. I'm not trying to hold things while also suturing at the same time. So it just makes things much simpler and allows you to see what you're doing. So that's why I'm using that tool for this. But this first suture is passed right through the middle there, so I'll tie it on both sides of that vessel to get a good tight closure on that. also should not really be picking up the needle with my fingers. So definitely not recommend doing that. You should use the tools instead.
Nice and tight.
So since that's anchored down the middle, it should not slide off of the vessels, so it's a nice tight hold on that.
Now I make sure I get a good hold and put this one over the crust tissue of this hemostat.
So I'm going to make one throw of my knot there, and then I'm going to remove that hemostat. I'll show you what that looks like. Alright, so let's get a better view of that. So you can see here, right when I first removed that, we have this layer of crushed tissue right there where the hemostat was sitting. Since that tissue has already been crushed and compressed, it will be much easier for me to get a very tight hold with the suture on it now that that clamp is gone. I could do this type of suture without crushing the tissue first, but it makes it a lot easier and a lot tighter of a hold if you do the crushed tissue first. The other thing to note, so I do have a tight hold there with that first suture that I placed, but it's important that we always do at least 2 sutures because these are really big blood vessels, and if I don't have a good suture on that, if there's excessive bleeding, it can really affect the health of the patient. They can even become anemic with too much blood loss. And sometimes you may even have to re-enter the surgery and find the loss of blood. So we definitely want to make sure to avoid that. So we always do at least 2 sutures because then if one of them fails, there's still a backup in place. But so again, right there is going to be where that crushed tissue is that I'll be tightening this suture down over.
Nice tight hold over that vessel. And put a clamp just above that here. Some gauze under here to protect the abdomen. And now I'm going to remove this ovary.
So again, that surgical laser cannot cut through the water that's on the gauze there. So because I put it there, I can make my cut to remove the ovary without worrying about the laser passing through and cutting one of the organs underneath.
Before I throw that, I'm going to remove this open and make sure I've got the intact ovary. Which I do. It's actually all the way in here, so I definitely got all of the ovarian tissue. Just good, that's our goal. So now I'm going to clean up this blood supply here with the charred tissue. Get this one clean. And before I release that back into the abdomen, I'm going to grasp onto it and just verify that there's no residual bleeding, because if there is, I will want to place more sutures. Unclamp it. No bleeding. Put it back in the abdomen. Still no bleeding, so we're good. So now I need to remove the rest of this side of the uterus. So I'm going to cut through this ligament here. It's the broad ligament that anchors the uterus down in place.
So I guess I should explain what I'm doing there too. So right here, that's actually a Spay hook. So Some people will make their incision and use this Spay hook to stick down into the abdomen and scoop up the uterus. I don't really like to do that. I typically use my fingers instead. So what I actually do for the Spay hook is I keep the handle side on my surgical table so it can stay sterile, but I hang this edge off the end and then I use it so I can move and redirect my my vacuum if I need to, as well as to hit that button on the surgical laser to turn it back on. So that's why I kind of hang that off on the edge there where you can't see it. I'm keeping half of it sterile and half of it not. So here's another good moment to see. If we zoom in on this part right here, you can see there's some bleeding coming out. So there's actually a vessel that's going up through here and then back down. Usually when I use the surgical laser, the smaller vessels, it will cauterize as it cuts, and I don't typically need to put a suture around them to close them off. But sometimes if the vessel is big enough, it will still bleed despite the laser, which is why we had to put the sutures on the ones attached to the ovary. But in this case, the one in the broad ligament was actually big enough that it is still bleeding. So I am gonna have to put a suture around that. But the reason I didn't suture it preemptively is because oftentimes when they're like smaller like this one, they don't typically bleed when we cut them with the laser.
Can I have some flat suture? Yep.
So I'm just kind of moving that tissue around so I can find the exact borders of the actual vessel. I want to close up the vessel, but I don't want to include a lot of extra tissue with it, because then if there's more tissue between the suture material and the actual vessel, it's not going to be as tight of a hold. So I'm just looking around in there and seeing where to hook my suture through to make sure I get a good tight hold directly on that vessel. It was hard to hear what I said there, but I said it was still bleeding, so I'm going to place another suture around it.
So cut through that. There's no residual bleeding there. Check this side. No residual bleeding there. And that's so good. Now the big thing is I don't want to hit these big vessels here.
So those big vessels I'm referring to are gonna be right there. That's actually gonna be the uterine artery. It travels right along the actual uterine body, and if I accidentally cut through that, it is going to bleed a lot. So I'm just going to hold it up there with my hand to keep it right up next to the body of the uterus, while I then break down the broad ligament lower than that. And then once I get the other side of the uterus out as well, I will then suture both sides. There's two uterine arteries, one on the right and one on the left, and I will suture those together with the body of the uterus. So right now I'm just going to hold it in my hand to protect it, to make sure I don't accidentally rip up through it, and then I'm going to continue to dissect through that broad ligament. That way I can reflect it up out of the abdomen.
I need to ligate those off with the rest of the uterus, so I'm going to just use my hands now to break down the rest of it. That side is done. I'm going to unclamp this so I can use it with the other one. And I'm going to place a new clamp so I don't get excessive bleeding out from here.
So the reason why I took that clamp off of that one and replaced it with a new one is because I want to use that retractor to also aid in my visualization of the other ovarian pedicle, so the vessels on the other side. But even though I've detached this ovary and uterus from its main blood supply, there's still blood sitting in those vessels. So if I don't put a new clamp there, it's just gonna essentially ooze out and make a big mess. The patient is not gonna have excessive blood loss because that's already been cut off, but it will still leak out from the material that I'm planning on removing. So that's why I put that new one there. It doesn't function really for much other than preventing the blood from leaking out.
Now we do the same thing on the other side. Okay, follow it up. There's the branch. There's the ovary up here.
So now we're onto the left ovary, and the left ovary actually does not sit as high up in the abdomen as the right ovary does. So you'll notice there's actually a little bit of a better visualization on the left side as opposed to the right. Some people will choose to do the left side first for that reason, but I prefer to do the right first because it's a little bit more challenging, so I like to just get that one out of the way. The same thing, I gotta break that suspensory down again with my finger.
Just take suspension ligaments. We work for it. Pretty good vessel there, so I'm going to suture on it preemptively. I could just suture that with the rest of the pedicle, but I'm just going to put an extra suture on it and make my life easier, not risk it bleeding and then having to find it. Just an added safety measure.
So basically what I was referring to there is I could have made my window on the other side of that vessel And then when I suture the vessels going to the ovary, I could have included that vessel with those sutures and just suture it all together. The downside of doing that, though, is that I'm including more tissue in my suture, and if I don't get a tight enough hold, I could still get some leaking of blood, and then I've got to try to look down into the abdomen and find exactly where the bleeding is coming from, and that's significantly more challenging than just suturing it from the get-go. And while looking for it, she would then be actively bleeding, so by doing it here, I'm preventing her from having extra blood loss. It requires a little bit of an extra step, but in her, it was worth it because I could see that the vessel was pretty good size. And then I just used the scissors there to cut between my sutures.
Okay, so same thing, I'm using the downline retractor again. You don't have to do this, but it definitely makes visibility easier, so I like to do it. But you would have to be careful. So, like, if I use this size retractor in like a small dog, their vessels aren't that big. I might run the risk of it tearing. So you do have to make sure to choose the right size for the patient. I have a much smaller one here, but that would be way too small to use on her. I'll do a slightly different approach with this one just because I've got really good visibility of it. I'm going to actually put the 2 clamps on. I'm going to do my crushed tissue suture first before the transfixing one. It just makes the transfixing suture a little bit easier to do, but same end result.
So same thing as before, I'm making the first throw of the knot, and then I'll remove that clamp and then tighten it right down in place. You can see up here in the corner, actually, the technician is monitoring during the surgery. Even though we have her hooked up to all the monitors, we still like to write down the heart rate, respiration, all of her vital signs, just to make sure that we are keeping track of it as opposed to just looking at a monitor. And then we can check for any changes. You know, if she starts to have trends and issues with her heart rate, we'll know it for future surgical procedures. She actually did really well. But this way I can look, see, hey, how did her heart rate do with this sedation protocol? Should I plan on using it for future ones? Do I need to tweak it next time? It just gives us good, valuable information. So again, I wouldn't recommend handling the needle with your hands. The downside of that is if I were to poke myself with it, I would be making a hole in my surgical glove. I didn't end up doing that, of course, but if I did, I would have to pause mid-surgery, change out my gloves. So it's better to just use your instruments and not take that risk, but it's unfortunately a bad habit that I sometimes have.
just not cooperating, but it's okay, I don't need it anymore. And the same thing I did last time, I use gauze to protect the abdomen while I cut the suspensory. Since I don't have the doweling though, I'm going to actually use a scalpel blade instead of the laser, just to make sure.
So the problem I was having was that it wanted to orient vertically out of the abdomen as opposed to horizontally. So I didn't want to laser through because then I could, indefinitely keep lasering. I didn't want to hit, like the side up here, her skin or anything.
For bleeding?
Couldn't position it how I wanted to, so that's why I ended up using a scalpel.
That's good, so I can put that. I'm going to remove the broad ligament again. Now I know last time the vessel was big and laser wasn't enough to cauterize it, so I did put the stitch, so I'm going to actually just go ahead and do that preemptively on this side. So I'm going to isolate that vessel, so it's actually this one coming down here. So I'm just going to go ahead and put some sutures in it so we don't get the bleeding that we did last time.
So I'm putting 2 sutures in the vessel, one kind of on the top and one below it, and then I'll make my incision between. That way I don't have bleeding from the patient, but I also don't have leakage from the vessel that's being removed. Then I'm just cutting through that broad ligament again on this side.
So this vessel was small enough that as I cut through, I was able to cauterize it, so I don't need to stitch that one.
So that's actually the second vessel. So here, down here, and up here was the second vessel. When I cut through it with a laser, it didn't bleed, so that's the one that did not need the stitch. Up here towards the front, that was where I had sutured. So this was actually a second vessel, and you can see there that, using the laser does end up cauterizing most of the smaller vessels. So that was just a good demonstration on how the size of the vessel makes a difference on if we need to put the suture or not.
Alright, so alright, now we have to suture the uterine arteries and body. And we'll be able to remove this all.
So again, there's uterine arteries on the side, and then the body of the uterus, which then branches up into the 2 horns. Cat uteruses are shaped very similar to dogs.
Go ahead and flip this, because she does have a little bit more tissue, so do the same thing that I did kind of on the suspensory. I'm going to do a clamp that way I can put it over crushed tissue, just make it come out better. one extra pack of gauze. And another aught suture. Here, I'll just keep the gauze, you can take the bone. And then we'll suture on this body of the uterus, and I can remove that.
So same concept, it's good to have at least 2 sutures on the important structures like the body of the uterus or those ovarian pedicles. That way there's always a backup plan if one of your sutures fails. Now when I cut this, the uterus is decently thick. So definitely more thick than the skin layer was, or the linea alba was, or even the vessels really on the ovarian pedicle. So you'll notice it takes me a little bit more to actually surgically cut through the uterus as well as those arteries. So I'm holding here the clamp in my left hand so I can kind of rotate it, and then I'm anchoring my palm on the body of the uterus up here. So I'm rotating away with one hand and pushing down on the other so I can get more tension, and that'll help me make a cleaner cut through the actual body and the artery there. So I've already cut through the one horn here, and now I'm removing the artery and the little bit of the remnants of the broad ligament on this side there. And then you'll notice on this side, so see how there's a little bit of bleeding there? That's because I started to cut through the uterine artery, but hadn't fully cut through. So it just takes a little bit more to cut through those tissues because they are thicker.
Clean that. Now there's a little bleeding, so it can go back in. I'm just going to check the abdomen.
So I'm going to show you guys a little bit there. So checking the abdomen, so you can see here there is a little bit of blood there, and that's because along this side I cut through the broad ligament. So it's okay for there to be a little bit of clotting because there's a lot of little tiny vessels that we didn't need to put stitches through. So these have formed clots already. I'm okay with there being some clot formation, but what I don't want is I don't want actual excessive bleeding coming through. I don't want to see any active bleeding, like blood flow. If I dab at the abdomen and remove any remnants of some of that blood there, I don't want to see the body replenishing the blood. So a little bit of bleeding because we have made an actual incision is fine, but we definitely don't want to see any blood pooling. So that's primarily what I'm looking for. The other thing that's important is I've got this gauze in my right hand here. I'm not going to let go of that gauze because if I'm dabbing the abdomen with it, it is very important that I do not leave that gauze behind. So I will keep it in my hand the whole time, because if I were to leave that in the abdomen, it could cause a really bad reaction, infection. The body does not want foreign material in it, so it's important that that never leaves my hand.
You will see seepage there from those small vessels, but no real blood pooling, so we're good on that side. Same over here. Don't see any pulsating blood or anything, so everything's closed up adequately, so we can go ahead and suture her closed.
So I'm using the brown adsense in my left hand there. They've got a smaller gripping area, but it's fairly flattened. It's not as sharp. There's other ones that have like 2 points that come down. We call those rat tooth. So I don't use those very frequently. I mostly use these brown adsense here that I have. I will swap those out for a different one when I'm doing the skin layer, just because that tissue is a little bit more delicate. But for the majority of things, I'm actually using the brown adsense that I have there. I only cut the one side of the suture because I'm going to do what's called a continuous suture pattern, which means it's just the non-stop line of it. And I'm staying right on that linea alba when I suture, which is that white connective tissue that we saw in the beginning.
So here, when I'm suturing this closed, I'm staying in that tendon as opposed to going down into the muscle layer. The reason being is the tendon is what actually gives us the holding power, and going down into the muscle really doesn't add much strength to it, but can definitely cause more discomfort. So it's just better to stay as much as possible in the tendon only. It's a lot simpler in dogs because the tendon is very thick. In cats, the tendon's quite narrow, so it's pretty easy to accidentally grab a bite of muscle too.
So for this layer, I'm using the OT suture, which is the biggest suture that I typically go for in dogs or cats. Cats, actually, I wouldn't use OT, but in dogs, OT is the biggest I go for. And the reason why I'm using the bigger suture on this is because it's the holding layer. So this is what really keeps everything tight and closed down. The rest is just to aid with reducing any leftover space, aesthetics, also, of course, patient comfort. You know, having open skin layers would not be comfortable. But this part is the most important layer. And needs the strongest suture with it. So you'll notice that as I go through the other layers, I will ask the assistants for different size sutures. OT is the biggest, 2-OT's a little bit smaller than that, 3-OT is even smaller, and then 4-OT is the smallest one that I use on this dog.
Can I have a 3-OT, please?
To the right.
just reverse that one so I can make a loop so I can tie the suture off now. And then I'm going to check for any gapping because I definitely don't want any spaces in this because that could set her up for having basically internal organs coming out, which would obviously be really bad. So we need to make sure that there's no spacing in this line of suture at all. So as soon as I tie this knot, that's going to be what I check for. Fix along this line, make sure there's no spacing. If I encounter any spaces, I will then just go back through and add more suture. And everything's looking good, so now we can go on to the next layer of closure, which is going to be the subcutaneous layer. Since that is not a holding layer, I am using a smaller suture size. We don't want to do too big of suture because it's going to be stronger than the tissues. It just increases the risk for suture reaction. I clearly have terrible aim for the trash can.
Oh, sorry, what I was trying to say there is that if you use too big of a suture, you could get more tissue reaction. But I was having a hard time not laughing because my assistants were making fun of me because I have terrible aim for the trash. And I'm sure you could see the little packet fly forward. I did not even come close to making it with that other one. And so this is going to be similar to the last line of suture. I'm doing continuous again. So same start, and then again I will only cut the one side of the suture. That way I can continue with the same line of it. I just picked up those brownettes and forceps again.
I am actually going to tack this layer down to my linear closure. And I'm going to take a bite of that. That pulls that sub-Q layer right down to it. The reason being is we want to reduce dead space, or basically empty spaces left behind. When there's empty spaces, the body likes to fill them with fluid. So you end up getting what's called a seroma, which is fluid accumulation underneath that skin layer, and it can be uncomfortable. So we definitely want to reduce the risk of that.
The other nice thing about doing the subcutaneous layer is you can see as I'm going along, these skin edges are a lot closer together where I've already stitched as opposed to the other side. So when I go to do my skin closure, the sides will already be a lot closer together. So it just makes things a lot easier, looks nicer, and again, reduces that dead space. I am having to dab a little bit at it with the gauze. The reason for that is because these layers have a lot of little blood vessels. So they're highly vascular, and it's really common as I'm sticking that needle through to poke through one of them. It won't cause any issues. The body just redirects blood flow if needed. I'm stitching it closed anyways, so I will be essentially closing up any leaking vessels regardless as I'm suturing. But I just like to keep it clean so I can make sure that I can see what I'm doing, make sure I've actually got the good seal that I'm looking for. But that's why there's a little bit more bleeding in this part. The skin will be the same thing. Skin is very vascular as well. be starting my knot soon as I'm getting towards the edge of the incision there. This knot will be a little different than the last one because I want it to end up buried underneath the tissue layer.
Now that I'm getting towards the end here, I'm going to want to bury my knot. To bury, that means that all of the strands of the knot have to end in the deep tissue. So this one I went from superficial to deep, so that's going to come out. Now I'm going to make a loop. I want the other end of the loop to be in the deep tissue too. So I'm going to turn my needle around, and I'm actually going to go from the deep layers up to the superficial. See my knot, and then I need a string to tie it to, so I'm going to go on this other side here, go from superficial down to deep, that way I can end in the deep tissue again. I'm going to pull that through. Now, if you see, this is what I've got left to tie with. This is coming out from underneath that tissue. This is coming out from underneath the tissue. So I should end up with a somewhat buried knot when I tie this.
Now, it's okay if this knot isn't perfectly buried because I'm still going to close the skin over it, but the more buried that this one is, the easier it will be for me to actually get the skin to cover this knot. So I usually do like the full buried knot and get it as deep down in the tissues as I can, just because it will make it easier when I'm doing the skin closure.
I'm going to press it in under here, up through the skin, and pull it down under. Right. A little bit better. Now I'm going to do the skin layer on top.
So now I've switched to a smaller suture.
Smaller suture for the skin layer.
I decided to start out with 4/0, but her skin ended up being thicker than I was anticipating, so you'll see I do end up switching back to the 3/0. Ooh, and that's a good shot right there too. So these are those other forceps that I was talking about. These are the DeBakey's. Their gripping part is this thin area there. So it's got a little bit of some like lines in the actual metal to grab you some gripping power, but it's fairly smooth, so it's not going to traumatize the skin as much. The skin is very vascular, but also very sensitive. So if I'm gripping it with some of those stronger forceps, if I pinch the skin too much, I can cause extra bruising. I can cause more patient discomfort. So that's why I've switched to this style forceps specifically for this layer. You can see here's my other forceps type up here. Those are those rat tooth, and then to the right of that was the brown acid that we were talking about.
Thicker. I'm going to end up going with the bigger suture after all for this. So I'm just going to remove that, and I'm going to go back with my 3/0 for the skin layer now.
And so here I've switched over to the 3/0 suture. It's a little bit of the bigger suture size. The reason I did that was because her dermal layer ended up being thicker than I had thought it was. And if I do a very small suture, it's easy for one suture to be like down here in the dermis, the other side to be up here, and then if I bring those together, they're not going to be lined up as well. So if I have a little bit of a thicker suture in that one, as long as the skin layer is wide enough to accommodate it, I can get that suture more centered in the dermal layer, and then when I pull it together on the sides, the skin layers are going to be more appropriately lined up. That will reduce scar tissue. It also improves healing though, because dermis wants to heal to dermis. The dermal layer isn't going to be as inclined to heal to the subcutaneous layer, or on the opposite, the epidermis. So it's just best to keep everything as correctly lined up as possible. So that's why I went with the bigger suture on that. The other thing too, when I'm doing the intradermal suture, I'm making the needle do the work. So if you see what I'm doing with my hand, when I grab that needle and push it through, I'm turning my wrist and allowing the curvature of the needle to actually guide me through that tissue. So if you watch here again, I'm going to start kind of on top of it, and then I'll rotate my hand as I'm pushing it through. You want to let the needle do the work, and I use the cutting needle. That way it's cutting straight through that tissue. If you're just pushing and crimping it, you're going to get too much friction along that needle, and it will cause more patient discomfort. So if you use the nice sharp cutting needle and allow that needle to do the job, you're reducing the trauma on the actual tissue. And since it's a small suture, the needle
vascular, which is why I'm getting a little bit of bleeding as I'm going. That's okay, because as I'm closing up the skin, I'm also closing up these little vessels that I'm poking through with my needle.
So that needle is really small, so if I'm not following the actual curvature of the needle, when I push it through, you'll start to see that it will get deformed. It won't maintain its nice curve, so you won't get the good normal curve of the needle if you try to force it. So mine is staying in that curved fashion because I'm using my wrist to allow it to do its work, and I'm not fighting the needle. The other nice thing about the intradermal too is that it's staying within that skin layer, and as healing occurs, there's going to be some natural swelling. And one area that can be really uncomfortable for some pets is if they get skin, like surface skin stitches instead. If the stitches are put too tight, as the skin swells, it will start, like that suture material will start to cut into it, and that can be really painful. But by keeping the suture in the dermal layer instead, if the skin swells up as it's healing, it'll swell up around it. That suture's not going to start cutting through it because it's inside the actual skin layer as opposed to sitting on top. It also gets a much tighter apposition of the skin layers.
Skin too.
And then I'm just starting my buried knot there. Same way I did the subcutaneous layer. I'm going to make the 2 loops and then come out to tie.
Again, both ends of this are in the deeper tissue. And then I'm starting to tie this. There we go.
So the other thing that I do here that you can see is that I keep my forceps open. The reason is I want to loop this side through the actual stitch loop, and I want to hold it open because if I clamp down on that loop, if I'm not perfectly centered in the loop, I may end up having one side come through more than the other. I may not get as tight of a knot on it. But by having those needle drivers open with the suture just looped around it, I can slide all along that loop and it will just naturally position how it should, so that way I'm not just doing an uneven tie on that.
I have some cervical.
So you can see here I've left that line of suture still attached. because I'm able to pull on that with my left hand, which kind of pulls that knot down in. So if I put the surgical glue on top of it, I will be pulling the knot down while putting the glue on top, so it'll just really extra hold it down in the deeper layers.
Put some glue over these knots to make sure they stay gluey.
And this, of course, is surgical glue. It's not just regular glue. It's meant to be used on the skin. And then I just have to apply some pressure there as the glue is setting, and then you'll see I'll end up removing my suture layer. I also learned the hard way that it's best to keep your surgical gloves on this. Because I did try to do this one time after removing my gloves.
Add a little bit of glue just for good measure.
Just adding a little bit of glue there, so see how I'm tapping it down. Doing that with the bare fingers is a really good way to glue your hands to the patient. Not ideal. Good news though, you can actually remove surgical glue with nail polish remover. So it dissolves in the acetone, so you can remove any glue after the fact if there are mishaps. But yeah, definitely easiest to keep the surgical gloves on for this part. All right, and that concludes the surgery. Thanks for watching. If you have any questions, please be sure to leave them in the comment section below. Also, don't forget to check out my other video on spaying. I have an informational one if you have any questions about deciding whether or not to spay. And if you want to see the non-narrated version, I do have a link to that in the video description below. If you like seeing these videos, please make sure to subscribe to the channel and don't forget to hit the bell icon so you get notified when the newest videos come out. I'm Dr. Meggs, and this is Everyday Vet.